Hi, thanks for joining. My name is Dr. Mac Drake. I'm a burn trauma critical care surgeon at VCU Health Medical Center in Richmond, Virginia, at the Evans Haynes Burn Center. Today we're going to talk about chemical and electrical injuries. Our objectives will be simple. First, we will discuss current management of electrical injury and pitfalls associated with the mechanism that they carry. We'll also discuss certain injury patterns. Then we'll review current management of common chemical burn injury. These signs are common worldwide. The first thing about electrical injury is to ensure your scene safety. If you ever come upon someone who's being injured, in the act of being injured by an electrical injury. If you notice, this is a group of school children. They're having some kind of a fundraising challenge by a local fire department. No one paid attention to these high tension power lines that are not too far away in the background. Somehow this arced. Two of the firefighters were killed instantly, and two ended up in a burn unit for a very long time. None of the children were injured, but scene safety is very important in electrical injury. Don't become the next victim. Damage to tissues occurs through several mechanisms. The first mechanism is the voltage of the electricity itself, followed by the current, then the resistance flowing through the tissues, and there's Ohm's law, just like we just discussed. Also, the duration of the passage of electrical energy through the tissues certainly plays into the amount and the extent of damage. Whether the current is alternating current versus direct current, and then the actual direction, the path that the current takes through the human body also affects and plays into how bad the injury is and the extent of the injury. So let's talk briefly about low voltage electrical injuries. Low voltage would be considered to be less than 1,000 volts. It's typically an alternating current source. Low voltage typically means that there is a prolonged contact time with the energy source. Since it isn't high voltage, it doesn't, if you will, explode and kind of blow the patient off of the contact with the source. A V-fib arrest is common in a low voltage scenario, as is tetany. Tetany so bad, so severe that it can cause even fractures and other sorts of trauma as a result. Burns from low voltage injuries tend to be more superficial. They tend to be limited to the skin and to its outer layers. They tend to have not passed through compartments extensively and have caused extensive muscle damage, etc. Compartment and visceral injury is rare with low voltage injury. As opposed to high voltage injury, which is characterized by greater than 1,000 volts of energy, it can be alternating current or it can be direct current injury, typically associated with a relatively short contact time. And the most common arrhythmia that we see with high voltage injury is actually asystole. Tetany is also common, as are injuries associated with it. High voltage electrical burns tend to be deeper. They tend to not involve quite so much cutaneous burn, but the burns may pass through compartments. They may pass through deeper tissues. Compartmental injury is quite common in high voltage injuries. And then we have the highest voltage injury of all, which is lightning strikes. Lightning strikes can be up to 2 billion volts. That's right. High voltage is considered greater than 1,000 volts. A lightning strike may be greater than 2 billion volts. Lightning is direct current only. The contact time from a lightning strike obviously is very short. It's fractions of milliseconds to very few milliseconds. Similar to high voltage injury, asystole is the most common arrhythmia when lightning strikes. There is variable tissue damage with a lightning strike. It depends on a lot of different factors. It depends on whether it was a direct hit, whether it was a patient who was standing next to something that was better grounded than the patient, but they received energy from that, etc. With lightning strikes, compartmental injury is relatively uncommon. One of the pathognomonic features of lightning strikes is called Lichtenberg patterns. Lichtenberg patterns is a very distinctive petechial skin pattern, and if you have ever seen that, even in representative text or in a case study, it's very characteristic of a line. So how do we manage electrical injury? Some of this is going to look familiar to you, no doubt. So of course we always follow trauma survey, so they get their ATLS, primary, secondary surveys. They get all of the appropriate workup and adjuncts. It's important to remember with an electrical injury that associated trauma is certainly possible, maybe even likely. These patients often sustain injuries as a result of tertiary and quaternary blast injuries. The next thing for an electrical injury is to treat the arrhythmia. So utilize your advanced cardiac life support. Use your cardiac arrhythmia treatment algorithms to try to maintain circulation with the patient. Currently, resuscitation in a patient, especially who has high suspicion for a current injury, electrical injury, is actually the old Baxter or Parkland formula. It's 4 milliliters per kilogram per percent total body surface area. And that's delivered in the same way, same manner that everyone is used to delivering the Parkland formula, which is half of that is given in the first 8 hours after injury, and the remaining half is given in the next 16 hours. And what this does, the reason that we give more resuscitation volume to patients with electrical injury is that we're trying to account for the unseen muscle damage that's beneath those obvious cutaneous burns. So we're trying to account for intravascular volume depletion early on in these people's hospital courses. An old teaching was to try to force diurese these patients using forced osmotic diuresis with a material such as mannitol. We don't recommend that anymore. You do have to have a high index of suspicion and watch out for myoglobinuria and watch out for injury to muscle and to compartments. But osmotic diuresis is not recommended. The most common presenting arrhythmia for all comers after electrical injury, regardless of voltage, is atrial fibrillation. We already discussed just peripherally monitoring for compartment syndrome, so especially in the extremities, you have to watch these compartments. If you're unable to get reliable serial compartmental exams, you have to consider using some more objective measure of determining compartment pressures, such as using a striker needle, using some kind of a mechanism to measure the compartments, or you have to consider prophylactic exploration and possibly even fasciotomy, opening of those compartments. Aggressive and early opening of compartments is associated with improved outcomes in electrical injury when there is damage within those compartments from current injury. Visceral injury is rare with electrical injury, but it is possible, so that should be noted on trauma survey and should be included in the spectrum of possibilities of injury when undergoing trauma workup. So let's talk about management a little bit. So low voltage injuries, anything less than 1,000 volts, especially when you're in your normal household range of voltages, so less than 220, 240 at the most, voltages that are injuries. So if the patients are asymptomatic, if they have a normal ECG, and they really have no significant cutaneous burn, nothing else that requires admission, those patients may be generally safely discharged home, just with an outpatient follow-up visit. They do not need to be admitted to the hospital for telemetry, continuous monitoring overnight, anything like that. It's a relatively benign injury given this constellation of findings. High voltage injuries, on the other hand, so greater than 1,000 volts, definitely deserve admission to the hospital. They should receive a minimum of 24 hours of cardiac telemetry, close pulse oximetry, close blood pressure monitoring. They should also undergo serial neurovascular examinations, as well as examinations or assessments of those extremity compartments. In a high voltage injury that's greater than 1,000 volts, an ophthalmology consultation is very important. I try to advocate for this in the patient's hospital course acutely. The reason for this is to rule out optic nerve neuropathy as well as fundoscopic hemorrhage as a result of the electrical injury itself. We also consider ear, nose, and throat team consultation to examine the tympanic membranes and to rule out tympanic membrane rupture if indicated. So who gets admitted? High voltage injuries get admitted, so that greater than 1,000 volt injury. Anyone who's symptomatic and having chest pain after an electrical injury, anyone with an arrhythmia or an abnormal electrocardiogram should get admitted for observation and for ongoing telemetry. Anyone with an electrical injury who also has concomitant trauma of some variety should get admitted to the hospital for monitoring and for supportive care. Also, we would advocate for anyone who has had loss of consciousness, anyone who has some kind of a neurological weakness or has a peripheral paresthesia would also get admitted to the hospital for monitoring and for ongoing workup and management. And then, of course, admit to the hospital anyone who you might have concern for current injury leading to injury within the muscle compartments of an extremity. So those patients certainly need to be admitted, and they need serial neurovascular examinations, even consider compartmental pressure monitoring. The cutaneous thermal burn itself, related to an electrical injury, whether it is an arc injury or whether it is a current injury, should be managed essentially the same as any cutaneous thermal burn. The patient, after initial stabilization, which includes the trauma workup, the ACLS workup, the correction of arrhythmias, etc., should undergo basic wound care with an initial debridement and then placement of dressings. Resuscitation with the formula that we just mentioned, the 4 milliliter per kilo per percent total body surface area of cutaneous burn formula should be based initially on the percentage of the total body surface area of the cutaneous burn that you see, as long as it's greater than 20% total body surface area. Less than 20%, we would not advocate necessarily for a formula-based resuscitation. You're just going to have to, watch the patient very closely, trend the urine output, trend the other markers of resuscitation, and see how the clinical course goes. Any patient with a cutaneous thermal burn as a result of an electrical injury, we believe warrants consultation with or transfer to a burn center. This is the American Burn Association's updated formula table that is the current recommendations for resuscitation. So this is for patients with thermal burns, cutaneous thermal burns, who need a fluid resuscitation because their percentage of total body surface area that is at least partial thickness is greater than 20%. For children, we have a slightly lower threshold, but nevertheless, this is the formula. So as you can see here, for electrical injury at all ages, they get the 4 milliliters per kilo per percent total body surface area. And then for flame and scald, adults get 2, so they get exactly half of what we would give an electrical injury. Children less than 14 years of age get 3, and infants and young children get 3. This is a very specific and special circumstance that I just want everyone to be aware of. This child bit into an electrical cord and has an oral commissure injury. So that's a full thickness injury right at the oral commissure. I'm seeing this infrequently, commonly from all of these new knockoff, non-factory endorsed mobile phone charger devices. A few years ago, if not a decade and a half ago, most electrical cords in the country underwent a revamp because these injuries were so prevalent. Now we're back to kind of this thin, kind of polycarbonate, sometimes even fabric braiding, and we're starting to see an increased number of oral commissure injuries. So These should trigger an automatic burn or plastics consultation for ongoing workup and management. You should consider oral splinting in these patients. I like to get occupational therapy and physical therapy involved in these patients' care very early. That way they can go ahead and customize a regimen for the patient to keep the mouth moving to try to prevent contracture. And then this is very unique to this injury, which is that there is a delayed eschar separation several weeks after this injury occurs, and that actually puts the patient at risk for hemorrhage from the labial artery. So that is a potential for patients who are managed, especially on an outpatient basis, which is nearly all of these people. So it's something that you need to counsel your patients about and educate their families, and certainly keep track and keep a close eye on these patients, utilizing your outpatient clinic and maintaining an index of suspicion that this is a possibility. As far as long-term effects from electrical injuries go, as far as long-term effects go, long-term effects present themselves in approximately 50% of the population that are affected by high voltage injuries. The most common long-term sequelae are neuropathies, and they can be either central neuropathy or peripheral neuropathy, as well as cataracts. Autonomic dysfunction is also common. It can manifest itself in a variety of manners, such as pupillary changes, hypotension, spinal cord injury, seizures, confusion, and even aphasia. Complex regional pain syndrome is also a possibility that can present as a long-term effect as a result of electrical injury, as can some things that we already touched on, which are inattention, poor memory and learning, etc. Moving on a little bit to chemical injury, I just want to briefly discuss some of the more common scenarios that you may come upon related to chemical injury. So there are greater than 70,000 chemicals in the MSDS database. The MSDS database is Material Safety Data Sheet database. So every workplace that's a commercial workplace that has chemicals in the workplace is required by law, at least in the United States, to maintain this database of what is being used by their employees. So when a patient is injured with a substance and sustains a thermal burn, a splash to the eyes, an injection, a ingestion of a toxic material, whatever the case may be, one of the first things one should do is consider locating that material safety data sheet. That'll give you potential antidotes. It'll give you some guidance on how toxic the product or the substance is, and give you a little bit of guidance. Also would have a low threshold to consult with your local or your regional poison control center. Potential mechanisms of injury affected by chemical injury are ocular injuries, which can be very serious. Obviously, cutaneous or dermal injuries, which also can be quite serious. Inhalation injury. Inhalation injury is a extremely serious mechanism of injury related to chemical injury, dependent on the chemical that is aerosolized and inhaled. And then, of course, toxic ingestion is another potentially fatal and very morbid injury related to chemicals. Factors that influence how serious a chemical injury is include the agent itself, the duration of the exposure, the area of the body surface that's exposed or involved, the concentration and the pH of the offending substance. So acids cause a coagulative necrosis, and the cutaneous injury tends to be more superficial with an acid. Strong acids tend to have a pH less than 2. Alkali, on the other hand, exert their effects through a liquefaction necrosis, which effectively causes saponification of lipids, therefore extensive tissue destruction. It also lends alkali substances to deep tissue penetration. Alkali are characterized by having being strong bases that have a pH greater than 11. So for a chemical injury, initial management, know the chemical, consult with poison control, consult with the material safety data sheet if available. Ongoing ABCs with an ATLS, trauma workup. These patients, just like all the other types of burn injuries we've discussed, certainly have the potential to not only have a chemical injury, but also have some sort of an injury related to blunt trauma and similar. One must be careful to mind the airway. Many chemicals aerosolize. A detailed body surface area estimate of the exposure to the chemical is very important. It helps determine the extent of the exposure. It also helps us to be able to monitor the cutaneous injury itself and to assess its progress. Additionally, many chemical injuries cause systemic toxicity, or they cause severe metabolic derangements and exert extremely morbid or even mortal metabolic effects. So chemical injuries should be decontaminated. That can also be based on MSDS sheets and poison control consultations. If a patient is coming in with a burn and it's a powder substance, don't wet it, just brush it off, keep it dry. Chemical burns with liquids, we would advocate for flushing with a minimum of 30 minutes of continuous irrigation. You can also use litmus paper, and you can irrigate to a neutral pH in the effluent. Very important to protect yourself when dealing with chemical injuries. You don't want to become the next victim, just like electrical injuries. So it's extremely important to remember that many of these chemicals aerosolize. When you're irrigating these patients, you don't want the water turned up extremely high on the sink or the shower or the decon area that you're using. You don't want to splash your coworkers and your fellow healthcare workers or yourself. You want to be wearing full personal protective gear when dealing with these patients. Eye protection, mask, hair covering, gown, nitrile-based gloves, the whole deal. With relatively few exceptions, antidotes are typically avoided when dealing with chemical injury and burns related to the same. The reason for that is a couple, but the biggest reason is that most antidotes create exothermic reactions, which just serves to worsen the cutaneous burn. And then identify and treat systemic toxicity or symptoms of illness related to chemical injury. So the one very specific chemical injury that I wanted to speak to you about today is a hydrofluoric acid chemical injury. Hydrofluoric acid is a common substance that's used in glass etching chemicals and in detailing products, household cleaners, car detail substances. Even dilute solutions of hydrofluoric acid penetrate tissue very deeply. The severity of the illness and injury and the pain that goes along with that, it is really dependent upon both the concentration and the total body surface area of the exposure. Highly concentrated, greater than 50% concentration hydrofluoric acid has been reported as fatal when a patient receives as little as 2.5% total body surface area exposure or contact with that concentration. Any hydrofluoric acid burn or exposure that's greater than 5% total body surface area, either splash of body surface area or thermal burn, we would consider to be a high-risk exposure. Water lavage is certainly the initial treatment, wearing that personal protective equipment, and the goal of that lavage being to work to a neutral pH. Systemic toxicity is the thing that kills patients in hydrofluoric acid exposures and injuries. The systemic toxicity is that the substance binds the circulating free calcium, uh, and then it causes a massive systemic and severe hypocalcemia, which requires immediate, urgent, and often surgical intervention, medical intervention, to try to avoid arrhythmias, try to avoid degeneration to torsade de pointe, etc. Hypocalcemia prolongs the QT. It does cause torsade. Treatment of hydrofluoric acid injury is primarily focused on the cutaneous burn itself. So just like any other burn, you should irrigate it until neutral pH. Also, debride the blisters just like you normally would, taking care to maintain your personal protective equipment. And then especially for finger and hand injuries, calcium gluconate made into a gel emulsification is actually quite helpful. It provides near immediate symptom relief. Put it in a nitrile glove, calcium gluconate 2.5% gel, and insert the patient's hands into those gloves. Leave them in there for 24 hours. Alternatively, you can do a subdermal injection, or you can do a infusion via the arterial line. Inhalation of hydrofluoric acid must be treated with 100% FiO2 oxygen, and it must be treated with nebulized solution of 2.5% calcium gluconate. Pulmonary edema also plays into morbidity and mortality in inhalation related to hydrofluoric acid, as does ingestion, which in the case of ingestion of hydrofluoric acid is typically fatal. Other circumstances that we won't go into great detail about with chemical injury include radiation injury, both from ionizing and other forms, chemical weapons injuries, which if 2020 stays on this trajectory, who knows if we'll be seeing those soon. Cement and plaster injuries, typically dry injuries when they come to the trauma bay. So most of the time, those need some kind of a brushing off rather than a wetting. Tar, hot tar is a big one, especially where there's a lot of road construction, etc. Hot tar is difficult to remove, as is sodium metals, especially when to air. I would point out that if you are not at a verified or regional burn center, that you can always reference and you can always invoke the American Burn Association's Burn Center referral or consultation criteria. There is a reference here for determining body surface area that's involved. There also are these 10 criteria that are rather liberal of situations in which you should seek consultation with a burn center, if not referral to a burn center. So you can always invoke these rules and look to your nearest burn center for support. Thank you very much. I appreciate the opportunity to talk with you today, and I'd be happy to entertain any questions.